Dear students, my name is Dmitro Fitkov. I'm Associate Professor of Internal Medicine, Department number 3, and today's lecture will be devoted to studying the musculoskeletal system examination in rheumatological patients. Let's get started with the small joints of the hand. Evaluation of each anatomical area consists of three main parts. The first part is inspection, the second part is palpation, and the third is an assessment of passive movements and active movements in the joints. We should draw attention to the joint configuration, presence or absence of deformities, and skin color during the inspection. It is important as a simple change in skin color can often indicate a specific nosology, such as bruising or redness with a cyanotic hue may indicate the possible psoriatic or reactive arthritis. Joints of patients with osteoarthritis usually not change in the context of skin lesions. In psoriatic arthritis, skin lesions and specific nail changes can be observed. So, we examine both limbs and then move on to palpation, starting with radiocarpal joints. During palpation, pay attention to the force of pressure. Pressing force is regulated by color control of the nail filings changed to white. This indicates a sufficient level of pressing. Examine both radial wrist joints and look at the patient's reactions, asking if he feels any pain during palpation. Then palpate metacarpophalangeal joints. For this, we put 2 fingers under the joint and 2 of the other fingers over the projection of the synovial membrane, checking for tenderness. In the same way, we check the swelling of the joints. It is better to do this in 2 passes. Check the tenderness first and then check the swelling. Continue with the proximal and distal interphalangeal joints. We also palpate each joint of both hands. Next, we turn to the palpation of the flexors. Simultaneously, we can check for the presence of tunnel syndromes. The most often of them is carpal syndrome, observed in rheumatoid arthritis and some systemic connective tissue diseases. After we complete the palpation, check the passive and active movements in the joint. Check for flexion and extension. Supination and pronation. Abduction and adduction. After, we ask the patient to make the same movements himself. After evaluating the movements of the radial wrist joint, determine the movements in the finger joints. We ask to bend and unbend the wrists. Determine the strength in the fingers. Then, active movements. First of all, opponent motions. Then, we test the muscle strength of extensors, trying to separate the fingers. We can also test the function of the extensors in the forearm lay-down positions. The whole palm should touch the table surface. At the same time, we see that all muscles and joints are symmetrical. Also, during palpation, pay attention to checking the skin's temperature over the joint, which is better to do using the back surface of the palm. Then move on to the elbow joints. For elbows, begin the same way, looking closely at deformities that may be in bursitis, the presence of swelling. Further changes in the skin, and proceed to palpation. Palpation of the elbow joint is carried out by applying fingers to the 3 dimples surrounding the olecranon, and the absence of the swelling and tenderness is a norm. We also palpate the ligament attachment sites to determine the presence of medial and lateral epicondylitis. Then we evaluate the range of motions, passive movements, flexion and extension, and similarly for active movements, asking to bend and unbend arms for flexion and extension through efforts to check for the medial or lateral epicondylitis. Painful movements will indicate the presence of this pathology. Then move on to the shoulder joints. Examination of the shoulder joints is also started with an inspection. Carefully examine the shoulder joint, sternoclavicular joint, acromioclavicular joint, focusing on skin color, scars, atrophies, rashes. Also, we assess the possible deformities of joints. Then proceed to palpation of the joints, starting with the back of the shoulder, then the projection of subacromial bursa, and the place of the long biceps tendon. The same for the second shoulder. Also palpate acromioclavicular joint and sternoclavicular joint. After palpation of the joints, palpate the lymph nodes, then turn to assess active and passive movements. Flexion in shoulder joint, extension, abduction and adduction. Also, the abduction, adduction, and rotations can be evaluated by putting the patient's hands behind his head. Thus, we evaluate abduction and external rotation, and by placing the patient's hand behind his back for adduction and internal rotation. Then we assess abduction through efforts for straight and flexed arm. In this manner, we evaluate the muscles of the rotator cuff. In the same way, through efforts, we assess external and internal rotation. The elbow should be pressed to the torso. The same goes for the second shoulder. During abduction, pay attention to the point where pain occurs. Usually, pain at abduction for 40 to 50 degrees testifies to the involvement of a shoulder joint. If there is no pain in this position, then the joint is not affected. If the pain is up to 50 degrees abduction, it is a sign of subdeltoid bursitis. Increased pain with further adduction can testify to the neurologic origin of pain. First of all, due to cervical and thoracic spine pathology. Examination of the back is also started with an inspection. Pay attention to deformities, skin color, scars, atrophies, rashes. After that, we pass to palpation. Determine the local temperature, palpate the muscles, and determine the presence or absence of tender joints, tender points during palpation of the vertebra. Pressing on the spinal processes and paravertebral. Pain on palpation paravertebral more often indicates the discogenic nature of the pain. Then turn to the assessment of movements. We ask the patient to lean forward without bending the knee joints to evaluate the Tamir distance test. Normally, the distance between the fingertips and the floor should be 10 cm or less. Now ask the patient to unbend, lateral flexion from right to left, and rotations, right to left. In addition, to assess the mobility in the lumbar spine, we can conduct Chavers Test. To perform the test, we find the lateral points of the rhombus of Michaelis and put two marks 5 centimeters below and 10 centimeters above the line that connects them, and measure the distance between these points. Then we ask the patient to lean completely forward. Repeated the measurements, the distance in this position. Normally, the difference between flexion and straight positions has to be more than 5 centimeters. To assess the restriction of the movements in the spine, it is also advisable to conduct the Forestier test. We ask the patient to stand close to the wall, and normally 3 points should contact the wall: occiput, shoulder blades, and heels. Examination of the hip joints begins with an inspection, paying attention to the same features we talked about before. After the inspection, let's move to palpation. Palpate the spines of the iliac bones and areas of trochanters. Pain in these areas indicates the presence of enthesitis and trochanteritis. Then proceed to evaluate movements and their volume, flexion of the hip joints, abduction, and rotations, external and internal. Then ask the patient to turn from his back to his side of stomach to assess the extension while determining the symptoms of tension. Their presence may indicate discogenic pathology of the lumbar spine. In addition to examining the hip joints in patients with suspected sacroiliitis, we can identify the signs of sacroiliitis. It could be Makarov's symptom, taping in the area of sacroiliac joints, and Kushilevsky symptoms, determined in the position on the side and back. Turn the patient to the right side and ask him to focus on the lower back and sacroiliac joints. Then press on the iliac bone. The pain during the test indicates the presence of sacroiliitis. Turn to back. Same pressure on the iliac bones, with asking a patient about pain in the sacroiliac joint area. The same goes for another side. Examination of the knee joint also starts with the inspection. Pay attention to the presence of deformities, skin color, the presence of rash or scars, atrophy. And then move on to palpation. Determine the temperature of the joints. To evaluate the presence of effusion of the knee joint, we can use the Ballotman test using the non-dominant hand to apply a series of down stroke from thigh to leg and then firmly grasp the upper part of the knee just above the patella. One finger of the dominant hand's thumb is used to push the patella backward against the femur. An increased patella waving motion or spongy joints feeling suggests the test is positive for joint effusion. Then assess the tenderness of the joint and pes anserina, attachment site for muscle tendons, and continue determining the size of the ligaments pathology. Evaluate the sign of damage of the anterior and posterior cruciate ligaments, signs of damaged collateral ligaments, lateral and medial, and signs of the meniscal damage, also lateral and medial, for one and the other limb. Next, assess flexion and extension of the knee joint and the sign of crepitation that is typical feature of osteoarthritis. Then, internal and external inversion. Therefore, continue with the patient examination to turn on the abdomen side. Test for presence of Baker's cyst that commonly accompanies knee joint effusion. Examination of the foot area also begins with the inspection, paying attention to the nails on which there may be lesions typical for psoriatic arthritis. During the inspection, also draw attention to erythema, rash, atrophy, and scars. After the inspection, move to the palpation. Assess the skin temperature over the joints. Palpate the ankle joint. Assess tenderness and swelling. Check for tenderness in the subtalar joints. And palpate metatarsophalangeal joints. Proximal and distal interphalangeal joints in the same way as for small joints of the hands. We can also find pain in the area of Morton's neuroma, usually between the third and fourth fingers. Then we palpate the site of plantar aponeurosis attachment. The tenderness in this area is a sign of plantar enthesopathy. Then assess flexion, extension, and rotations for both feet. After, ask the patient to turn from his back to the stomach side and finish with palpation of the Achilles tendon, assessing tenderness and swelling of bursa and attachment site. This concludes our assessment of the musculoskeletal system in a rheumatological patients. I wish you success in acquiring new knowledge and see you at our department. Thank you for your attention.